saying thank you for inviting me to talk. Just here?
Yeah, that's the one.
Okay. I just want to talk about work that we've done over the last year, and it sounds very organised, but it's actually like usually these things, it's developed a little bit as things went. How it actually started was from 2014, I've been asked to do a couple of detailed reviews of 3 tumour streams. Obviously they were tumour streams that Paul had some concern about, but it became obvious when we did these that there were a lot of generic issues and that we should take this further. So we then, and I have to thank Nicole very much for this, we thought we needed to do a survey to start off, and Nicole kindly offered us the same survey that she has been using. So we surveyed everyone, and we now have 180 responses to the survey. And then we thought, as usual, that we'd organise a workshop, and the outcomes of that workshop wondered what to do with it, but in the end we put everything into a matrix, which I'll talk further about later, rather than just documenting what people said. And all that has come together into the Tumour Program Strengthening Initiative, which we are now running. So this is just the detailed reviews. I have to go a bit quickly because I think I'm a little bit over time, but really they just set the scene, and I think they gave the doctor some trust that we were going to do things in detail and not brush over things. They also a little bit, that just shows the New South Wales hospitals are in pink, and Victoria and New Zealand from Sydney are in blue. And it showed that even though we look all right compared to the New South Wales hospitals, when you compare us with New Zealand or Victoria, we're actually performing not very well at all. So then we did the survey, and once again thanks to Nicole, we've now got 180 responses, mostly medical, staff 13% nursing, 9% allied health, overall 21 different teams, most meeting weekly and most discussions. This is the people's perceptions of what happens. It's not necessarily correct, but that's the members' perceptions. Most discussions 5 to 9 minutes. So I'll just go through some of the collated responses very briefly, but I think this shows what that film was talking about, that when it comes to treatment and diagnostic decisions, we're doing very well, most perceptions, but when it comes to things like education, morbidity and mortality, looking at risks, the perception of most teams were that they weren't really doing that very much at all. Just a few, just sort of to a reality check. How 24% believe there are established criteria for referring patients to that, we're calling them tumour boards. 20% believe they had terms of reference. 62% felt they usually follow clinical practice guidelines, and 45% stated that the patient preferences were incorporated into the discussions, but less than 12% said they had a way of liaising with the general practitioner. So we just as extra questions, we asked, these are the Cancer Institute, the information that they require from us, and we members really felt that we collected most of those data, which was good. But when it came to asking about the performance indicators that the Cancer Institute are asking the 4 pilot teams to collect, across the board we didn't perform very well. And when it came to psycho-oncology screening, there was very, very little, very little that the team members believed was happening. So the next thing I did was actually take all of that collated results and then individually analyse the teams, the separate teams, and went back to them with their results. I've now completed going back to all of those teams, and I think it was good because it wasn't comparing us with Harvard or the NHS, it was actually comparing each team with their colleagues in the network. And we separated it into sort of 4 groups when going back to them. And I've just got 4 examples. They're all different teams, and I alternate one that's not so good with one that is good, just to show you the spread that we have. This is, are there established criteria for referral of patients to the meetings? Overall, 30% of teams said yes, but this team very definitely said no. No one even was not sure. Everyone said that there was no mechanisms for referral. This one was, is there a follow-up process to check whether referrals from the MDT are actually made? Overall, there was only a 15%, but for this team, 57%. They obviously had a very structured mechanism for following up whether referrals actually happened. On what basis are treatment decisions made? This is another tumour board. Obviously what we're trying to do is get this to get lower, but the average for the organisation was 36%, said it was ad hoc. On this team it was 64% of responses said they had ad hoc decision making. And finally, does the MDT use clinical practice guidelines? 65% overall said usually or always, but this team 100% said that usually or always. And I know that team, and at the end of every meeting they say what they're doing and what protocol it is. It's very organised. So we've then chosen 6 of the questions that we felt none of the clinicians could argue that they were not important. The first one was terms of reference, but are there established criteria? Is there a follow-up process? Does it use clinical practice guidelines? Does it routinely collect the time from diagnosis to treatment? And does it ever conduct audits? And as you can see, there was very widespread across. I have to say these teams tend to be the ones that have more resources, and certainly the ones that have live data entry. That one isn't. I think it was a pretty impressive performance for a team that doesn't have resources. But when you look down here, you can see there's really not a lot happening that we would like to happen in multidisciplinary teams. So simultaneously with this, actually, we had a workshop to see where we should go, where we should follow it up. And from that workshop, from all the outputs from it, I sat down and the idea actually came from Tim, I have to say. He doesn't know this, but and did a framework looking at with 5 levels of, it's probably not performance, it's probably levels of sophistication, going from 1 basic to 5 superior. And then 5 components: governance and leadership, organisation and logistics, linkages with GPs and patients, infrastructure and human resources, and data collection, analysis and research. Each of those have 4 sub-components. So in the end we have 100 boxes. It was designed in theory, and there's no scientific basis to it, it's just me taking those responses and from what I knew. But the idea is that most teams should be at level 1. It says things like robust and open discussion, the meeting has a chair. I felt our teams our best teams were probably about level 3, and level 5 was way out there. It's everything, having protocols, having open notes. It's really quite out there. But most of the things were actually discussed. So this is what it looks like and what we're asking teams to do. And I have to say that this has got a little bit of traction, but it's very early stages yet. We're asking the teams to just themselves go through and say where they think they're up to, whether they, not comply, but whether they do these things. So they just highlight if they think they have that, robust and open discussion, chair, environment where dissenting opinions encouraged. And then when they do that, we can make a full box green, if it's half filled, orange, and if it isn't filled, it stays white. And hopefully over a few years, and we're thinking this is probably a 5-year project, but we're hoping over a few years we can move the green along that direction. There's only 1 team that's actually filled that out. There's another 4 that are in the process of doing it. And this is the thing that when I present to them, I present this, but I ask them to go off and do it in an outside meeting. I don't really think, I think it's better if I'm not there because I think there needs to be robust and open discussion. So that's where we're targeting right at the moment. So I mean, basically we think it's a practical method to engage streams at various stages of maturity. We've had enthusiasm from the teams. I've been surprised how much positive feedback we've had. And we've had overall acceptance of the survey and the matrix. But as I said, that the matrix is just really starting. What we want to do is repeat the survey annually, matrix annually. They work on their weaknesses, and gives us the matrix also gives us an idea of where we should be as management, targeting improvement. And this is what we've got for 2017. I imagine it's the same as most of the networks around New South Wales. But to me, the database and live data entry is number one priority by far. We've got the terms of reference. We're looking for a fit-for-purpose meeting room. And with the thanks to Natasha, who's in the audience, we've actually got quite a good database now. So that's all. Thank you to Paul and the teams, Tim, and once again to Nicole.
Well, maybe Sally, you weren't over time at all.
I wasn't over time.
You're under time.
I didn't realise I only had 20 minutes, and I've given.
No, that was kind of perfect. So that's great, Lynleigh. So thanks.
I could have been.
Do people have any questions for Lynleigh?
No.
Maybe this is a naive question, but are there, obviously clinicians from various cancer indications in the room, but are there also, for example, basic researchers?
There are in some, particularly Gyne-Onc has a big research team there, led by Anna. Probably most of them, some of them might have one or two clinical trials people, but a lot of them don't. One of the things on the matrix is actually on getting clinical trials people into the meetings, but I think it's about level 3 or level 4.
Yeah. Can you just use the mic? So I think would that make it easier for you? Yeah. Probably just go to the room. It's more to go through for me.
Thank you. I was just wondering if there was a general consensus from the clinicians that those attributes in Band 5 are things that they want to be aiming for.
That's a very good question. I have to say I expected a lot more of them to come back, and my feeling is perhaps they haven't really read it very thoroughly because most of them aren't there. But I did take it to the head of the Division of Surgery, and his only comment was, oh, you might get a bit of pushback there. So it wasn't a, you're ridiculous, this is, it was, I can't remember exactly, but the surgeons mightn't like that something. So it's been remarkably well accepted. But having said that, not many of them are very close to level 5. And some of them I say, don't worry, because I'm imagining that's a few years off. And by that stage, either it won't be as way out there, or we will have decided to change somehow, I would imagine.
I mean, I was really impressed by the uptake of the clinicians when you ran that workshop, Lynleigh. It was kind of an invitation-only workshop, not to be exclusive, we just had a limited space, didn't you? It was during the Sydney West Translational Cancer Research Centre meeting, and it was massively oversubscribed, wasn't it? Everybody heard about it and all wanted to come, and they all had an input into it. I think one of the keys is it's pretty non-judgmental. I think that's one of the things. It's not saying you've got to be here, it's not punishment, it just gives you a guide. Are there any leads? I know Nirmala's obviously a leader of this. I mean, do you think it would be useful for you, Nirmala, having these kind of, for the team to be able to track its progress? I guess that's one of the things I quite like. Rather than a snapshot, it's actually gives you a progress.
Yes, I think I liked the program because it gave you a way that you could improve. So it gave you a sort of a way that a lot of the MDTs sort of work in isolation. I work at the Breast Cancer Institute at Westmead, and we have actually 3 or 4 MDTs running every week. So it was good for us to actually look at our different MDTs and see where our weaknesses and strengths were. And also I like the fact that you could you had a methodology whereby you could actually improve your MDT. So I thought that was useful, and that was useful for us.
One thing I should say is that every time I ring up one of the heads of the teams and I say, we've got all your data for the survey, can I come and take it's about 10-15 minutes to report it, and I expect sort of to be told I'll be given 5 minutes in 3 months' time, and nearly always they say, oh, what about next week, or what about the week after? So they really have been interested. Having said that, that's the survey results, not the matrix. So. But even the teams that have performed poorly have been very interested to get. And some teams have made changes on the spot. One team had almost 0 for education. They said, oh, we must introduce a 2-monthly professional development meeting. So there's been uptake.
Nicole?
Lynleigh, I'm just wondering if you can comment on whether you have any tools or resources to implement with each of the teams. So, you know, like a checklist, going back to Fran's presentation around having actual, like a generic terms of reference or a set of resources that the teams can use so they don't have to reinvent the wheel.
No, we have. We've developed terms of reference, which are really a guide to the perfect meeting. And I've sort of said that these are tools for them. We're not going to test them or anything like that, but they are a guide, and I think having the discussion going through them would be a major advantage. So that we're going back with that with the matrix and suggesting they do those both at the same time, go through them. I mean, we've developed a checklist just for getting a database running, things like that. But at the moment, that's our priority, is getting a database in and the terms of reference for this year. I mean, resources are a major issue, and I've looked at the international literature, and the amount of admin support for MDT coordination never seems to be enough, and certainly that's the same with us. Having a dedicated lead clinician, we've got one who has a little bit of funding, and that's made a vast difference, and care coordinators as well. But resources are very tight at the moment. That's why the billing, we're trying to get the billing in to try and get some more resources for care coordinating, if not for admin support.
Any other questions? I think Emily's not here yet. She's in the clinic, I think, when coming across, but I think Emily reflects on some of that as well, like some of how you can get over, because I don't think you necessarily need millions of dollars. Emily had great success with a couple of MD students actually helping her with a database capturing stuff with a very small grant, and that can be quite transformative.
We've just got one of the Cancer Institute innovation grants to get someone to help with getting the databases into all the teams, so that will be great. And the other thing we're trying to concentrate on, we will give them tools for this, is the liaison with GPs, and we've got a lung cancer project, and Melanie's here and doing a lot of work which we will hopefully just expand to all the other teams to do that. Okay.
Oh, question about
Vincent.
Olivia, you have a few carrots, but you haven't provided me stick. As opposed to the slide, the MDT I go to, you're keen, but
there are some sticks,
I mean,
but we're not advertising them very broadly at the moment. I mean, one of the sticks is actually the Can Refer website, where the Cancer Institute says people should attend 75% of meetings to be a core member. So
I don't think that anyone is doing an audit. I mean, I talked to them recently from Cancer Institute. They're not updating anything. Every time that I email them and say, you put my pictures up, or take this down and take that down, it take them a long time. They're not keeping.
Actually, you're on our list to ask about that today, and I said to Natasha if we can catch Vincent this afternoon. But and I think we have to do that. It would be too cumbersome to do it in retrospect. We are trying to divide the teams into the team lead, the core team and the non-core, and on the database they're designated like that. We would expect the core team to be the can refer team.
Having said that, I mean, is that something that we need to feed back to the Cancer Institute? Because we've read that can refer, even from the beginning, they've been very slow at making corrections and changes. So if they really want it to be a good functional site, they need to have mechanisms in place to respond more briskly to changes that are needed.
Actually, when you look at the website, it's actually quite hard to navigate. It actually takes a long time before you can find it.
Yeah.
They can only get to log into the website and no email.
I'd have to take that up with the...
They will respond.
I know Natasha spent a lot of time trying to reconcile our database with the Can Refer website. But
I mean, given the Cancer Institute's here, I'd give them kind of right a response to that, I guess. I mean, obviously it's a big challenge. I've been involved in Can Refer right from the beginning, and I know it's a challenge to get that up, but obviously you've done a lot of work on that. So, Fiona, would you like to comment on that?
So I think if you're talking about in terms of self-management, so what you're talking about for the updating.
Say for example that I just started another MDT and it's always private. When you submit your stuff, it's easy at the beginning. But then I told them 6 months, if they are not 75%, I'm going to cut them. But then when you log in, I need to check all the conditions where they're on the website. A lot of the people that are on my list, on the new MDT, that they say they will come in, they sign up, they say that they promise they will do 75%. They are in another MDT that they haven't been for 1, 2, 3 weeks. They left the hospital, they're not doing it, but somehow that there's no mechanism to take those people off.
Well, we actually do 6 monthly updates and we've just completed one. So we have just updated that.
yeah, I mean, and that's what we've been trying to do. We're a bit slow, but yeah. I should say also there is a thing there that says obligations of team members. I mean, this is obviously self-filling in. It's not exactly a stick, but we are trying to express that there's obligations for us, but there's also obligations for people to be part of a team.
It kind of sort of comment. I think this is pivotal. The Cancer Institute be very helpful and is trying very hard with this. It's a collaborative thing. I think we're really lucky in the state to have the Cancer Institute as a body that's really willing us to obviously have that in the country, but maybe if it's quick.
Just around one of the sticks is actually we do around measures for block funding that we provide for MDT support is actually coming in for this financial year that you provide your updates to Can Refer, so as to the lovely Camille here, and Fiona, which is every 6 months within 4 weeks of being requested, and then we try our best to get that updated very quickly. So if there are problems, please email us and let us know, because unless we know, we can't actually respond to the issues.
And I have to say we've been a bit slow on this one. We found there were quite a lot of changes where it's almost ready.
Yep.
So I think what's really important is when we are doing the 6 monthly updates and we do request for the MDT to update that information and send it back to us, that is done quite rigorously, and that's the only way that we can, at the moment, keep the site up to date.
I have been to the Upper Georgia MDT for 9 years now. I've never seen a request of update. There's one done in the Lynleigh MDT.
I have to say that's not the Cancer Institute. They did ask us to go.
Yeah, but then unless the party
But Natasha and I just had so much trouble just reconciling the list this time that we haven't gone back to the team. But we will.
I suggest we take this offline. Obviously, it's a really key issue. I think this is part of that maturity model. Up until now, it's been pretty damn hot, really. There's not been an understanding of who's on the teams and things like that. And then, I mean, there's real consequences of that. Obviously, like the Health Pathways project that Nicole and I worked on, where we're putting in referral decision prompts in radiology X-rays, in CT reports for people with suspicious lesions, and that's linking directly into the kind of information within Can Refer. So we've got to start to get this right, as that becomes a real resource, and obviously updating. And it's something I think we're having these debates because it's actually becoming meaningful that that information's correct as well. And obviously you're starting to look at funding linked to these issues
It's
as
linked
well.
to funding as well
Yeah,
from
so-
the new financial year,
yeah.
so it's even more imperative to get the updates in and make sure that Canberra is a really robust resource for the state.
And I mean, our database is just a Tumour one, which Candace showed me how to do. But when we get that, we'll be much more easily able to update when that's accurate, because they should